Yes, Dr. Maria, if there are any pertinent questions, some of the questions were already actually answered on the chat. But I think I would ask Raj once again to probably answer a couple of them, um, especially about first, I think Dr. Klaas Haak, who had written a very detailed answer, because there's a lot of confusion about Dr. Haas about the quick clot differences from quick clot. But what I know, basically, quick clot is for external hemorrhage. Generally, because it is exothermic and it's not very, sort of friendly to the tissues. What would you say?
I actually have never seen quick clot in action, and I thought they solved this issue with the exothermic reaction. I think it was based on zeolites in the past, and it had a huge hemothermic reaction leading to severe burnings in extreme cases. Now it contains kaolin, which is a mineral, and I thought they had that solved. Has anybody
Right.
of you ever used that?
Now, so we don't have any sort of experience of quick clot also. We use generally tissue glues, but we don't have any experience of quick clot, especially inside the body, inside the tissues. It's been popularized generally for extremity trauma in pre-hospital setting, and that too, sort of by the pre-hospital care people. Raj,
Okay.
any experience about?
Yeah, so similarly, we use Celox dressings, which are also an externally applied dressing. Has a little bit of a hypothermic reaction as well, more for packing of deep wounds, but not within the abdominal cavity. And again, I think for more bleeding, which is within the abdominal cavity, we're using other tissue sealants like Flow Seal and Tissel and other hemostatic agents, local hemostatic agents, fibrinogen bases to basically achieve local hemostasis.
Right. Dr. Aventura, any of you, Dr. Meena Singh, any experience with quick clot with the chitosan based?
No, I haven't got any experience in this. And just like Raj mentioned, we use Flow Seal, Bioglue, T-cell, and we don't have experience in quick clot.
Yeah, in the Philippine Heart Center, we don't have experience with the quick clot as well. We just use the Flow Seal and the Bioglue. That's it.
Yeah, we use it more in the military setting, a bit on the pre-hospital as well, and it comes in our military kits in the field especially for these deep wounds before transfer to the next echelon of care.
Right. Thank you. Some of the other questions posed by Dr. Vincent De Villa Jr. Were about the applicability of the product which Haas showed to transplant bleeders, and how far it can sustain the bleeder in operating field in the operations. Dr. Haas, would you like to answer that question?
Yeah. The thing is, generally, the product is not supposed to replace any conventional measures. So if you have damages that you would normally ligate, please don't abstain from doing so. For a case like this, the product is just meant as an adjunct. For all other kinds of bleeding, where you at the moment use maybe T-cell or something like that, gauzes for a dry field can replace them easily. So
Okay.
depends on the kind of hemorrhage you have.
And I think just to add on as well, I think these products are really useful helping in the overall management plan. But when there's an ongoing coagulopathy, that has to be addressed concurrent to this for these products to work well as well, I would imagine.
Sure. Thank you. When do you decide shunting in peripheral vascular injury cases? Raj, I think you should answer that question.
Yeah, so I mean, to me, shunts are a very useful adjunct. We don't use them enough, I feel, especially when we think that we can get away with a quick bypass, which is often far longer than what we usually estimate. I think shunts are very useful when you expect that if the ischemic time has been quite long. Certainly, anything more than 4 hours, I would tend to decide to put in a shunt early. So that when I'm harvesting my veins and when I'm preparing for the bypass, at least there's flow and you're reducing the ischemic burden during that period of time. It's also particularly useful if there's a complex orthopedic repair which has to be done concurrent. And if there's going to be a lot of movement, I'd rather put a shunt in, let the orthopods do their work, X-fix, and then go with my definitive repair. It's the type of shunts you use. There are many different kinds of things you can use, but to be honest, all you need is some kind of a silastic tube which you can tie to the two ends of the vessels, from IV infusion catheter, Nelliton catheters, any kind of thing which allows blood to flow through. But just remember that when you establish a shunt, always keep checking that the blood is still flowing, that it hasn't clotted up. And then your shunt will survive. You can use the commercial shunts, the Pruitt Ishihara shunts, the Javits shunts, and all, but they tend to be a little bit shorter. So often for long segments, I find that it's not enough, and then you have to use some of these off-label use tubings for shunting. What do the rest of you use for your shunts?
No, we don't have any specific shunts with us. We would, in fact, use any silastic tubes. A smaller, French chest tube, which is slightly more softer, or even a vial, a bigger vial tube. I don't know, yeah. Dr. Maria, have you used shunts before? What kind of shunts? Your voice is not very clear.
Aventura, yeah. Dr. Aventura can probably share a few of his
I use Medtronic shunts for the coronaries in my off-pump cabbages and mixed procedures. Most off-pump surgeons would actually use shunts rather than just putting in a just trying to put a a bulldog or what or putting a tie around. But this is because there's a lot of ischemic burden in coronaries. So that's why it's always good to put in a shunt. Now, I would expect that to happen also in the vascular area, especially if there's a reperfusion injury after.
Yeah. So next question, probably first to Dr. Aventura and then Raj, is that what are the roles of anticoagulations and antiplatelets? Dr. Aventura, you must be doing some aortic, repairs, both in when endovascular stents are used or shunts. Grafts are used, or without grafts. What is your policy of using anticoagulants, whether intraoperative or postoperative, and antiplatelet drugs?
Well, in our setting, we always use antiplatelets for if we do it on pump, then we do one just aspirin, and then if it's off pump, we use aspirin and Plavix for about maybe 3 to 6 months. But if there's a big like we change the aorta, for example, we put in a graft, we have to give some anticoagulation as well, maybe about 3 to 6 months as well. Okay, Dr. Raj?
So I think for us, approach slightly different. So if it's if you're doing anything infrainguinal, that means at the femoral vessels and below, certainly we would start them on some antiplatelets. Below the knee, if you were doing any intervention, I tend to put them on dual antiplatelets as well. But above the knee and infrainguinal, a single antiplatelet. If I put in a TIVA, let's say for an aortic transaction, because of the high flow, actually the risk of thrombosis is quite low. So we do nominally put them on a single antiplatelet, although I think the evidence for that is not particularly strong. For patients who have a history of procoagulant tendencies, and of course, then that's when we will start using anticoagulation. In the trauma context, however, this whole discussion becomes quite tricky. because of the concurrent areas of bleeding. And certainly those with concurrent head injuries becomes really tricky now as to when to find the best window to start. Not just for the protection of your shunts, but also for general VT thromboprophylaxis as well.
Right. Dr. Meena, a question for you. So if the femorals are no go for a REBOA, what do you do?
In that case, we had experience of inserting from the via the brachial artery or use the axillary artery, but up to date, there's not much data on the use of upper limb arteries to access to put in a REBOA. But this is a good alternative because in our population, for the elderly aorta, many a time it is very tortuous, calcified, and sometimes stenotic. So in case there's a problem with the insertion, for example, if the wire doesn't go up as easily, and then we would then go for the brachial or the axillary approach.
Another question, Dr. Meena, for you is how do you remove, or you already mentioned in your presentation how you remove it, I mean, change to 8 French and then try to remove the balloon. I would be more interested in asking you, what would be the timing? Would it be in the ICU finally? I mean, generally in your cases, where have you removed the balloon?
The
Or the
balloon,
sheath?
the sheath or the balloon?
For the balloon and then the sheath, yeah.
Okay, for the balloon, many a time, almost most of the time, it is removed in the operation theater because we use the same sheath for angioembolization. So after removal of balloon, and then we'll proceed with angioembolization, and the sheath would be kept to be removed in the ICU after the coagulation status has been corrected, and then we will be removed in the ICU, or we can remove in the next operation because sometimes many a time these patients need to come back to the operation theater for second stage operation, so it can be also removed in the subsequent operation. But for an 8 French sheath, as I mentioned, we would suggest to use a percutaneous closure device to close the arteriotomy to avoid the hematoma formation and possible pseudoaneurysm.
Right.
Could I ask a question to Dr. Meena Cheng as well?
Yes.
When you put in your REBOA, how do you ascertain that you're not in the zone 2 or you're inflating near the renal arteries?
And we use the external landmark because we don't have a continuous fluoroscopic guidance. So many a time we would use the external landmark like the umbilicus, and then we would just put the balloon just above the umbilicus. And then for zone 1, we would use the sternum, and then we use the second rib. And if it is just at the second rib level, then most of the time it is safe. And especially when you see the guide wire is going up straight instead of going like to the renal arteries or the SMA. Because if you put in the balloon in these visceral arteries, it would be a disaster because these visceral arteries would rupture definitely.
But you would never actually just put some form of dye just to see or what?
Pardon?
You never put in some dye to see if they're you're in the right place or not, like in conventional angiography and stuff.
Yeah, in emergency room, we don't use contrast, but for ruptured abdominal aortic aneurysm, the balloon will insert it in the operation theater. Then we have contrast because for quick access to the REBOA, we don't have contrast on hand, and we don't have continuous fluoroscopic guidance. So at most we have 1 or 2 X-ray shots, and then we will need to inflate the balloon. So we don't use contrast to confirm.
Thank you.
Thank you.
Question to anyone can answer. With the REBOA, is there any learning curve after your training with the REBOA? once you use it with the patients or you apply it to your patients, is there any learning curve of how many cases that you should be doing first before you can actually proceed with applying it to your practice?
I believe there is a learning curve. That's why we start with fracture first, because for zone 1 inflation of the balloon, it carries more possible complications and risks. So we start with the zone 3 reboa, and we can have a longer time of inflation. So we have time to familiarize with the whole protocol, how it's carried out. And after the smooth implementation, then we can introduce the balloon in zone 1 for those with a fast positive. And we set the learning curve to be around 50 percutaneous puncture with a Seldinger technique before this doctor is considered independent.
There's also
Yeah.
a question. I think I can rephrase this for Dr. Hake, sorry. Would application of too much powder cause large lumps of powder to form? And if so, and it dislodges, would it be considered a foreign body inside the patient?
I don't think that we have seen that. But I also do not know why you would use too much powder. You just have to apply enough to reach hemostasis. Afterwards, powder does not have any beneficial effect, only gel would have. And the gel is generally easier to degrade than the powder. So if you're in doubt, then after you have reached hemostasis, I would always advise to drizzle remaining powder with saline or ringer lactate solution, so degradability is increased.
Okay. There's also one question. Any speaker can answer. Arteriotomy for thrombectomy, should we do proximal or distal to the occlusion?
Raj?
Any of the speakers can
Sure.
answer.
We would tend to do proximal to the occlusion, establish the inflow, and then of course work on the outflow as well. So almost always proximally.
Okay. And Dr. Gupta, after your arterial repair, do you heparinize and how do you do it?
So we use just intraoperative heparin systemic for one, and that too, if it is contraindicated, we would just locally heparinize the vessels, both proximal and distal. We would not use systemic anticoagulation there. But yes, one shot of 5,000 international units of unfractionated heparin will do the job for about next 1 hour or so. So I think that's it. Post-operatively, we've done a pilot randomized control study recently concluded, just had 32 patients. We'll continue that study, but again, no adverse effect, but then no advantage also of using post-operatively. So I would not suggest post-operative use of anticoagulation.
I have one last question. Any experience regarding autotransfusion? I think this is
Dr. Aventura, because you're a cardiac surgeon, you must be using autotransfusion.
For me, in most of my cases, it's standard. I don't usually transfuse. It's very you don't need that much blood, autologous blood to and it's actually very easy to use. You save a lot of blood. Definitely, all cardiac cases should have standard. Standard.
We listen a lot about autotransfusion in trauma. Raj or Dr. Meena, any sort of experience with that? We've not had that in the ED because we don't have a cell saver in the ED. But neurosurgeons very frequently use cell savers for cranial procedures.
Yeah, we do. I mean, to be honest, I think it's the setup and the time required for the cell saver to be set up, which is usually the bigger barrier to a rapid laparotomy that you're entering in. If certainly there's time if there's some delay or there's some time to bring to the patient in the theatre, I would preferentially always use a cell saver if I'm expecting significant blood loss. But in real life, I think by the time you get the patient in the theatre and you crash him open, you often haven't had time to really set it up, and everyone's going to be running around, and that drops down the priority list in terms of the logistics to be done. But to be honest, if all things being equal, I would love to have a cell saver when I'm operating for major trauma all the time.
For us, we have a cell saver in the operation theater. So once the patient is in, and then we do like the REBOA or the resuscitation in the emergency department, we would simultaneously inform the operation theater to set up the cell saver. So for us, the time is often enough for it to be set up. So when we anticipate massive hemorrhage, we would set up the cell saver first.
Right.